It's an honor for me to introduce our final speaker, David Greenfield from Bascom Palmer, and he's going to be talking about what to do when the visual field and OCT don't match.
Well, thanks very much, Teresa and others, and good morning. Here's my disclosures, none of which are relevant to what I'll be discussing. So let me try to wrap up what you've heard this morning and try to put it all in perspective. Sanjay Asrani said earlier that nerve fiber should agree with the optic disc, which should agree with the macula, which should agree with the visual field. Yet we have so many instruments, and there are so many parameters, and there are so many measurements and data. What do you think the chances are that there'll be good agreement? I mean, for gosh sakes, Richard Lee is showing you normal values in a prosthetic eye. So the reality is you're not likely to see this type of agreement. And in fact, the toughest part of my entire presentation was to find an example of something that agreed quite well. And this is what I'm going to start off by showing you. And this is an eye with very good structure-function concordance. And this is an eye with advanced glaucomatous damage, followed for 5 years with annual structural tests, annual visual field tests. And over the course of time, you see that on the glaucoma progression analysis, there are serial changes in the supratemporal portion of the retinal nerve fiber layer that did correspond nicely with the superior changes in the macular ganglion cell interplexiform layer, which did correlate nicely with the changes in the infranasal visual field. And looking at the baseline and the 5-year follow-up panoramic map, you do see those changes highlighted with the asterisk, identifying this gradual atrophy. This is what I see more commonly in my clinical practice, and again, an eye with advanced glaucoma, where there was progressive visual field loss, and over the course of 6 years of follow-up, there were serial optic disc hemorrhages that I've highlighted here with the arrow, and yet during the same interval of time, 6 years of follow-up, no changes by event analysis detectable in the nerve fiber layer or in the macular region. So there are a lot of reasons to explain this type of structure-function disagreement, and gosh, many folks from various institutions across the world have discussed structure-function relationships. This is a really nice study that Felipe Medeiros and colleagues from San Diego showed that explained in part this discordance based upon the fact that there is a non-linear relationship between structure and function, such that it is very much dependent upon the stage of the disease. So eyes with very early glaucomatous damage, why they may have very small changes in visual field mean deviation, but much larger changes in their retinal nerve fiber layer thickness measurements over time. And conversely, eyes with very advanced glaucoma, why they may have large changes in their visual field mean deviation, but yet small or perhaps no changes in their average retinal nerve fiber layer thickness. This is data from our group that was collected by Alex Wynn, and I'm showing you this data for 2 reasons. The first is because it nicely illustrates the relationship, again, that discordance that all the speakers have shown between structure and function. And this was a group of 147 eyes that we monitored for the course of approximately 5 years with annual OCT measurements of the nerve fiber, of the macula, and annual visual field tests. And this time, however, we classified the severity of glaucoma using the 2011 ICD severity codes, which you see distributed here on this histogram. And I'm showing it to you to show you that on the left bar, which is identifying the proportion of OCT GPA progression events in all 3 categories of disease, why they far outnumbered the proportion of visual field GPA progression events. And as you see from various other slides, this Venn diagram is showing you that a small proportion actually had changes identified with all 3 metrics, approximately 7% of the group. I also, however, want to point out that in this classification scheme with ICD, even eyes with severe glaucoma, we did identify much more structure-based progression endpoints rather than visual field progression events, because these eyes are not as badly damaged. The many of them have visual field loss close to the central fixation, which is why they're classified as severe. So why this discordance? Well, I mentioned that testing sensitivity depends, of course, on disease severity, and you've heard from many of the speakers that particularly in eyes with severe glaucoma, there is the problem associated with measurement floors. But on top of that, the analysis methods differ, and regions of retinal topography may not directly correspond with the same regions of visual fields. There's also the problem comparing linear versus logarithmic scaling. We know that all tests have a certain degree of variability, therefore confirmatory testing is required. And yes, the problem with red disease and poor quality data. This happens to be a very, very common occurrence, and this is data from Sanjay Asrani that showed the frequency of imaging artifact is common and affects imaging, it affects our clinical decision making. You might see in as many as 20% of the nerve fiber images some degree of artifact, and much more in macula, particularly in those eyes that have a macular pucker. There are a number of ocular factors that will contribute to this: high myopia, interestingly not astigmatism, but increased axial length, significant punctate surface disruption, mediopacification, vitreous floaters, and so on. Joel showed you many of these case examples. Here's an eye with nystagmus. You can see the blood vessels deviating on the bottom. A PVD is shadowing artifact, a blink artifact, algorithm failure in an eye that's highly myopic. So what should the clinician do when you see a poor quality test? Well, of course, you must repeat it. Here's an example of an eye with little or no detectable structural damage and good signal strength. 6 months later, repeat scan, whoa, it looked like glaucoma had declined dramatically. But if you look carefully at the algorithm, there was algorithm failure, the signal strength was low, the eye had significant corneal punctate epitheliopathy. You just repeat that scan with a topical lubricant and all will become well. Well, the second thing you should do when faced with this kind of discordance between structure and function is be careful to use change detection algorithms that carefully measure change and avoid the summary parameters, such as just average thickness values, because they tend to be insensitive to localized change. And as Felipe pointed out, you must carefully assess the rates of progression in order to determine the velocity of change. The third thing that I tend to do is I incorporate ancillary tests such as the macular scans as well as central visual field tests. There's very good data that the central 6 millimeters of the macula correlates very nicely with the central 10 degrees on visual field tests. And there are new visual field algorithms, such as the CETA Faster 24-2C, that now incorporates 10 central points in addition to the 54 standard points. We know these tests are very useful in severe glaucoma. They're also useful in eyes with early glaucoma, such as this eye with a paracentral defect, an abnormality that could be clinically seen in the superior arcuate nerve fiber bundle, but it escaped detection on the parapapillary nerve scan. But we did see this uncovered in the macular GCIPL. Documentation of optic disc hemorrhage has consistently been shown in clinical trials to be a strong predictor of progression. It's also a very useful biomarker when trying to reconcile differences between structure and function. And finally, there are the challenges to imaging patients with severe glaucoma due to the reduction in signal-to-noise ratio. There are floor effects in these eyes, and a high proportion of them are associated with algorithm failure. So to wrap it up, as you've heard from all of us, structure and function measurements often do not coincide. Both are necessary. Artifact is common. It will impact our clinical decision-making skills. Please incorporate macular imaging as well as central visual field tests. They're very useful adjuncts. And certainly consider measurement floors when interpreting scans in patients with very severe glaucomatous damage. Thanks very much.